Good afternoon, ladies and gentlemen. So I think we can get started. This is a very important topic about using the induction in kidney transplant patients to optimize outcome, how this induction can be tailored. Professor 𝐍𝐚𝐬𝐬𝐢𝐦 is a very senior nephrologist from France, and his work in this area and also other aspects of transplantation is very well known. And we are looking forward to hear him how to optimize outcome of kidney transplantation patients by using ATLG. Professor Qamar, please.
Thank you, Mr. Chairman. Thanks for the kind invitation. It's my first time in India. I'm very happy to be here to try to discuss a little bit how can we use ATLG to optimize the outcome of our kidney transplant patients. So here are my disclosures. And we will start with the main causes for graft loss currently. The main cause for graft loss currently is the death of the patient with a functioning graft due to cardiovascular disease. And the other causes of graft loss are ischemia reperfusion. It depends on the donor type, on CNI toxicity, rejection, the relapse of the primary disease, infections, and as I said earlier, the cardiovascular risk. And with respect to rejection, we can now distinguish clearly the two kinds, the T-cell mediated rejection and the ABMR, the antibody-mediated rejection. And there are some risk factors for the occurrence of de novo DSA that are the younger age, some HLA mismatches, the CNI-free regimens, and non-adherence to treatment. If we look for the effect of the DSAs on the occurrence of ABMR, it has clearly shown since several years, more than 10 years ago now, that patients with, who develop de novo DSA have a worse graft function compared to the others who have no DSAs. And there are two kinds of acute rejection that can occur when the de novo DSA occur, either acute ABMR, and you can see it on the upper part of the left part of the slide, or you can have a chronic ABMR, which is currently the more frequent. We have very few acute ABMR, but we have chronic ABMR, and currently we do not have any real treatment for this chronic ABMR. So how can polyclonal antibodies in general and ATLG improve the graft survival? I will focus on some few points because I have only 20 minutes. One of them is trying to give polyclonal antibodies to decrease the risk of diabetes and therefore improving the cardiovascular outcome and to decrease the risk factor of cardiovascular. Secondly, I'll present you some data on the effect of ATLG to decrease the relapse of some glomerulopathies, to avoid CNIs, and their effect in decreasing the acute rejection rate. If we look for, if we try to stratify the risk, the immunological risk factor of our patients, the first level are non-HLA sensitized patients. So we are discussing about patients undergoing a transplantation from an ABO compatible, HLA compatible. So these patients are considered to be at low risk of acute rejection. And in this setting, you have three possibilities of induction therapy. The first one is not giving any induction therapy. We can transplant the patient without induction therapy only if the patient are receiving a tacrolimus-based immunosuppression. This is based on the results of the Osaka trial that included a large number of patients, more than 1,200 patients, and it has been observed that we can give tacrolimus-based immunosuppression without induction therapy. On the right part of the slide, you can see a paper of our group that's now under revision, when we looked retrospectively for nearly 600 patients without any induction therapy. All of them were non-HLA sensitized, and you can see that after 2 years, the incidence of DSAs was very low. It was 3.8% in the whole population, 1.8% among patients without induction therapy, and 5% among patients with induction therapy, and very low acute rejection rate. However, you can do this if you are able to monitor tacrolimus trough levels very early after transplantation and daily, and to target a trough level that is around 10 nanogram per milliliter to avoid the acute rejection. If you are giving a low dose of tacrolimus, it will not be sufficient and it will increase the risk of acute rejection. What about using basiliximab? Basiliximab is now recommended by the KDIGO to be used in this setting in non-HLA-sensitive patients. It's based on previous studies. One of the old studies from nearly 20 years ago that compared basiliximab to thymoglobulin, and it showed that both were efficient to prevent acute rejection. However, there were more CMV infection and more leukopenia in patients receiving thymoglobulins. And if you look on the results of the Symphony trial that included a large number of patients, you can see that patients receiving low-dose TAC with basiliximab was very efficient. So basiliximab can be used in this setting. What about the use of polyclonal antibodies? The use of polyclonal antibodies, they can be used with any associated treatment, any CNI, and it can be used also on belatacept-based immunosuppression, which means patients with CNI-free regimen who are now at lower risk of graft loss. And in a large meta-analysis, it has been shown that given polyclonal antibodies compared to all the others is associated with less acute rejection. So the safest way is to give polyclonal antibodies if you are not able to give tacrolimus, if you're not able to monitor it and to give high load. What about the second category of patients, which is patients who are highly sensitized for HLA, but who do not have a preformed DSA? So I are discussing with high immunological patients without preformed DSA. Based on some studies that were performed before the Luminex era, it has been shown that it was preferable to give thymoglobulin or polyclonal antibodies compared to basiliximab. The first paper by Brennan published in the New England Journal of Medicine, the biopsy-proven acute rejection rate was 15% on thymo compared to 25% on patients on basiliximab. Another study was done in France, the TAXI trial published in AGT, and it also showed a higher risk of acute rejection in patients giving basiliximab compared to patients giving polyclonal antibodies. And last, a study compared daclizumab, another anti-IL-2 receptor blocker, to grafalon, and showed that both were similar. And you have to keep in mind that all these studies were performed before the Luminex era, and it's quite sure that some of the patients were grafted already with preformed DSAs. This is why we have conducted a prospective study in this category of patients. Patients have a CPRA above 50%, having at least one antibody with more than 5,000 MFI, no historical DSA and no DSA at transplantation, and with a negative CDC cross-match at transplantation. Patients were randomized either to receive grafalon, 9 milligram kilo at day 0 and then 3 milligram kilo day 1, 3, and 5, according to the RCP in France, and the other part were receiving basiliximab. And all patients were monitored for DSAs, for BK virus, and have protocol biopsies. What we observed that the number of patients was quite low. It was a proof of concept study that included only 30 patients in each arm. And even if we had 30 patients in each arm, we did not observe a significant statistical difference between both. However, the composite endpoint that was biopsy-proven acute rejection, death, graft loss, or loss of follow-up was much better in patients receiving grafalon compared to patients receiving basiliximab. 30% in one arm compared to 19%, and at 1 year, 36% compared to 24%. What about the incidence of biopsy-proven acute rejection? Again, the biopsy-proven acute rejection was significantly lower in patients receiving grafalon compared to patients receiving basiliximab, 3.6% compared to 15.6%. Only one patient given grafalon has a TCMR that was treated successfully with steroid pulses. However, on basiliximab, the number of acute rejection was higher. What about the kidney function and the kidney histology in this patient? As I told you, the patient had protocol biopsies. Kidney function was similar in both arms, and histology was also similar in both arms, as well as proteinuria, which, in other words, the primary endpoint was better in grafalon and less acute rejection. What about the graft loss and patient survival? We did not observe any difference between patients on grafalon and patients on basiliximab. The third category of patients are the patients who are receiving a graft with a preformed DSA, which means the HLA incompatible kidney transplant patient. I will not go through all the data, but it's now absolutely admitted everywhere that these patients should receive polyclonal antibodies if they cannot be grafted without any induction therapy and on basiliximab. In patient given standard desensitization protocol with apheresis, rituximab, IVIG, patients are given polyclonal antibodies. And on the right part of the slide, you can see now the new agent that we can use for desensitization is imlifidase. And our French protocol for using imlifidase in a highly sensitized patient receiving a kidney from a deceased donor, polyclonal antibodies are absolutely requested. And the last category is the patients receiving ABO-incompatible kidney transplantation. I know that in India, the majority of the patients are receiving a kidney from a living donor, and you may have a category of patients receiving a living donor with an ABO incompatibility. The early data published nearly 20 years ago from Japan suggested that the patients are at low risk of acute rejection, and the patients were sometimes not receiving any induction therapy or receiving basiliximab. However, it seems to be quite different when we started to do ABO-incompatible transplantation in Europe and in the US, and the results are a bit different. And we started initially with basiliximab, and then we moved to polyclonal antibodies. Mainly in my center, we are using ATLG. And we did a retrospective study, and we looked for the acute rejection rate in patients receiving either basiliximab or polyclonal antibodies. And you can see that the acute rejection rate was significantly higher in patients receiving a kidney, receiving basiliximab. And conversely, ABO-incompatible transplantation given polyclonal antibodies had the same acute rejection rate than ABO-compatible. This is why, after having started with basiliximab and ABO-incompatible, we completely stopped it and we moved to polyclonal antibodies. And as I'll show you later, it's ATLG in my center. And by means of a multivariate analysis, you can see that the use of polyclonal antibodies was an independent predictive factor of not having an acute rejection compared to basiliximab. As I told you earlier, the patient, one of the risk factors is the death of the patient with a functioning graft of cardiovascular disease. This is why we are trying to avoid steroids in some patients, especially if they have some high risk for diabetes, post-transplant diabetes. And if we look for several meta-analyses, you can see that in patients given steroids and not given steroids, the acute rejection rate is significantly lower in patients receiving polyclonal antibodies compared to IL-2 receptor blockers. And this is correct in living donors, and it's also correct in deceased donor. You can see that the acute rejection rate was lower in patients receiving polyclonal antibodies compared to patients receiving basiliximab, especially, and this is quite clear, if you want to avoid the use of steroids. In these meta-analyses, I combined all ATGs, right, Thymo and grafalon. So can we give ATLG, so grafalon, to avoid steroids? Those are the results of a French multicenter study called the Francia study, in which the patients were all given ATLG. and they were randomized to receive either steroids or not steroids, and they were giving the full dose of ATAG. And you can see that in patients without steroid, as expected, the acute rejection rate was a bit higher, but the most interesting is on the upper part, on the lower part of the slide, at 5 years, the graft survival at 5 years and was exactly the same. So, and it was quite very good. It was more than 90%, showing that if we give ATLG, we can stop steroids, and at 5 years, graft survival was very good. However, the time to acute rejection was lower, so the acute rejection occurred earlier if we stop steroids, and this is quite in line with all published results. So we discussed on the role of polyclonal antibodies on the acute rejection. What about the effect of polyclonal antibodies to avoid the recurrence of initial glomerulopathy? You can see that most of primary glomerulonephritis can recur after transplantation. And if we focus on the most prevalent one, which is IgA nephropathy, the recurrence can occur in up to 50% of patients at 5 years, and it's around 30% at 2 or 3 years. There were some retrospective studies that showed that the recurrence rate was significantly lower in patients receiving polyclonal antibodies compared to patients receiving either basiliximab or not any induction therapy. And if we add polyclonal antibodies and steroid, the risk is better than patient without steroids. In other words, these retrospective studies are in line of using ATLG or ATG at least in patients transplanted for IgA nephropathy. This is why we conducted a prospective study in France. The data are not published yet. Professor Maya from Saint-Etienne sent me his slides. We included in the study patients who have a biopsy-proven IgA nephropathy before transplantation, first transplantation, and all had a CPRA below 50%. And the patients were randomized either to receive ATLG or to receive basiliximab. And all patients were receiving tacrolimus, MPA, and steroids. And all patients had to have a protocol biopsies at 1 year and 5 years to detect a recurrence of the IgA nephropathy. With respect to steroids, it was up to the center to choose if they can give or not steroids, but you can see on the lower part of the slide that the proportion of patients on steroids was absolutely the same in both arms. Here are the results. We included 160 patients. We were aiming to include 220, but finally we stopped the inclusion in the study. If we look only for the clinical and histological relapse, we can see there is a high trend to better result and less recurrence in patients receiving ATLG. We did not reach the statistical significance because of the lower risk, low number of patients included in the trial. But if we look on the real histological relapse criteria, which is not clinical because we know that proteinuria can be related to something else than IgA nephropathy, there were a real difference between ATLG and basiliximab. Patients receiving ATLG had a lower relapse rate compared to basiliximab patients. What about the other observed effect? Infections, BK virus, CMV, acute rejection, etc., etc. There were no difference between both. We had a tendency to have less graft loss in the ATLG arm. It's here compared to the basiliximab arm. So when we discuss polyclonal antibodies, so it's ATLG or TIMO. There is no head-to-head comparison between both polyclonal antibodies. There are some meta-analysis. This is one meta-analysis published in 2020, and they tried to include all the criteria and with all the bias that can have a meta-analysis. They observed that there were a trend to have less delayed graft function, a better patient survival, a better graft survival, and less infection in patients receiving ATLG compared to patients receiving thymoglobulin. So once again, those are the results of a meta-analysis, and there are some biases in the meta-analysis, but if we include all 27 studies, those were the results that were published in 2020. One important point, I think now, at least in some big centers, is how many doses should we give to the patient and how long will patient will have to stay in the hospital and when he will discharge. For ATLG, we have the possibility to give it once at transplantation and not to give any subsequent dose. This is a quite old study in which patients were receiving either the standard dose, the 303 milligrams per kilo per day for several days, or receiving only one dose of ATLG and 9 milligram kilo at transplantation. And in this study, which was quite old, the patients were receiving cyclosporine A, azathioprine, and steroids. And they observed that the results were quite similar between patients receiving ATLG once or giving several doses of ATLG. So I still have some few seconds. So what's our strategy in our center? In our center, this is what we are doing now for patients who are not included in a clinical trial, because we are participating in several clinical trials. If you are participating to a clinical trial, the patient will respect the clinical trial. Otherwise, if you have an ABO-compatible, HLA-compatible, non-HLA sensitized patient, our strategy is not to give any induction therapy and to target a high tacrolimus trough level immediately. However, in patient, if the donor have a long cardiac arrest, it's not really the case in India because we have very few deceased donor, but it's not quite important in France. If you have a young patient who had IgA nephropathy, who lost his graft from IgA nephropathy, we give ATLG one dose. For ABO-compatible, HLA-compatible, HLA-sensitized patient without preformed DSA, we have the choice between, as I showed you, between basiliximab or ATLG. Usually we use ATLG except if the patient has lost his previous graft of infection, a severe infection of a BK virus nephropathy, or if the patient have a previous history of cancer. For ABO-incompatible patient, all patients are receiving ATLG and not receiving basiliximab. For a patient with preformed DSA, we use one dose of ATLG. So you can ask me, you are not using TIMO at all in your center. We are using very few TIMO in my center because we prefer giving one dose and stop. So in conclusion, polyclonal antibodies are a very effective induction therapy that is used after kidney transplantation. It can play an important role in improving the outcome, as I showed you, including the recurrence of IgA nephropathy and some others. It's efficient to preventing acute rejection. And one of the advantages of ATLG is that it can be given at one dose. I did not test TIMO with one dose in my center. And thank you for your attention.
Great talk. I just need to ask you one question. Where in your center would you decide to use ATG, and when would you decide to use ATLG? The problem that we have is that we have a choice of many. I do understand that Simulect or basiliximab may be a relatively weak induction agent, but I wonder when you would choose ATG over ALTG, or when you would use the others. So,
as I showed in one of my last slides, we nearly not use TIMO anymore. We prefer using ATLG one dose rather than using different doses of TIMO. TIMO is currently used only in one protocol that is ongoing, the use of imlifidase for highly sensitized patients. So we decided that all France will use the same induction therapy. Otherwise, in my center, except if a patient had any problem within the previous transplantation with ATLG, we have otherwise we do not use thymoglobulin, very few. We can use thymoglobulin in some severe acute T-cell mediated acute rejection for treatment, but not for induction.
The second question is that suppose you have an ABO incompatible transplant. Would you use a high dose of ATLG, a single dose, or would you use it spread over the next 4 or 5 days?
No, I use only one dose of
9 milligrams per
Yeah,
kg?
and we have published our data. It's not here. We have published our data of 150 patients, and we give only one dose of ATLG 9 milligrams kilo. The way to give one dose is just not to have to think about the other doses, and the patient will discharge earlier.
You don't see a higher incidence of BK nephropathy with ABO incompatible with a polyclonal antibody?
Yeah, you're right. This was one of the points that we had initially, a little bit more BK virus nephropathy in this patient. And this is why in our protocol now, all patients are converted from MPA to everolimus at day 15. So since we convert all the patients to everolimus, we do not have a BK virus anymore.
Sir.
So I am Dr. Ramchandra from Bangalore. My question is there are two drugs which are used in the treatment of ABMR, that is antibody-mediated rejection. One is eculizumab, and other one is for the prevention of this, that is IDS, that is imlifidase. Let me start with the eculizumab. You know that eculizumab, I have reviewed so many articles. It was not found to be extremely good in the treatment of rejections when compared to the hemolytic uremic syndrome secondary to the complement factor deficiencies. So in this setting of a already proved ABMR, what is your experience with the eculizumab? You know that we suspect it is the classical complement pathway is involved in this particular antibody-mediated rejection, wherein the HUS is the alternate complement pathway. So there is no logic in using this one. So I want to know the use of eculizumab in the ABMR. Second issue is imlifidase in the treatment of rejection.
I'm really sorry, but there's one important point that we need to make is that the time is running out and we need to finish the entire lunch symposium by 2 o'clock. So I'm really sorry, sir. If you could take this question offline over a cup of coffee, I believe sir would not mind that. And at the same time, can I just request Dr. N.K. Mehra, sir,
I can answer in 2 words.
Till the time you say, can I just invite Dr. N.K. Mehra, sir, to give the mementos? Go ahead, sir.
Yeah.
Yes.
So for eculizumab, we use it for ABMR, especially when patients with very high DSA and those who have the DSA that are binding the C1q. For imlifidase, it's another question. It's only for approved for deceased donors, and it's not used for treatment. It's used for desensitization protocols.